So I don't know if any of you guys know Monty Python, or maybe you guys are too young, but now for something completely different. Microwave ablation for colorectal cancer. Different disease process, different expected outcomes, and different modalities for treatment. And so just keep that in mind. So where are we today with metastatic colorectal cancer? Well, at the time of diagnosis, 15% of your patients are going to have synchronous, meaning at diagnosis, they already have liver disease. And over the course of their entire disease process, 40 to 50% are going to develop metastatic disease to the liver. As of today, surgical resection is the only what's quote unquote the curative intent treatment. However, only 20% of patients will be candidates for this. The TransMet trial, which was released last year, showed that transplantation might have a role in these patients. However, that was a very, very, very selective group of patients with very, very defined criteria. We have a liver transplantation pathway open at my hospital. We have unfortunately not transplanted a single patient yet because it's so restrictive. So because of that, there's a need for adjunctive therapies beyond systemic therapy because most of these patients are not going to be able to get to quote unquote curative intent therapies. And so why do we call liver resection a curative intent therapy? Here is a meta-analysis looking at a whole bunch of the different studies and trials for surgical resection. And more importantly, I just want to highlight that our 4-year or 5-year overall survival in a lot of these different groups and average out over time is about 40%. So that's our goal. So again, as we were talking about HCC, we had a much higher, 4 or 5-year overall survival. We're talking 70 to 80%. Colorectal cancer is different. And again, it's a different cancer. So in your mind, when you're treating these types of patients, you have to have different goals and different objectives, or else you're going to find yourself getting somewhat disappointed. Colorectal cancer is just a more aggressive disease. So when we talk about some of our local therapies, that is our goal. We're trying to get about a 40% 5-year overall survival. So for first-line colorectal cancer, like I said, surgery was the gold standard. And why is it considered the gold standard? It was this trial. It's called the CLOCK trial, which is the chemotherapy plus local ablative versus chemotherapy alone. What I really like about this trial is that it was actually an ablation trial, but since the patients were offered surgical resection, they considered it a surgical resection trial. Most of the patients in this trial actually ended up getting radiofrequency ablation, even though this is a quote-unquote randomized surgical resection trial. So 119 patients were randomized to either get surgical or chemotherapy alone versus chemotherapy plus some combination of ablation and or resection. Most of the patients had 4 to 5 tumors, and they, for the most part, got a laparoscopic radiofrequency ablation. So it wasn't percutaneous, although we'll get to that. And 50% of the patients had both RFA and surgical resection. So at the first analysis, after a couple of years, so you can see here at the 4-year readout time period, there was some understandingly disappointment. As you can see, the 2 survival curves in this trial were exactly the same. So we were kind of saying, is there even a role for doing local therapy in this patients? They seem to do just the same whether they got chemo versus surgical resection, and we were kind of, upset. However, the important thing is that this was a 10-year trial and not a 4-year trial, because as we go on over time, you can see the patients who ended up getting resection ablation did significantly better. Or at least a subgroup of these patients did significantly better, as you can see here. And so even though the 3-year overall survival was like 1% better in these patients, I really want to highlight the 8-year overall survival benefit is 36% in the patients who got ablation versus 9% in the patients who just got chemotherapy. Unfortunately, it's really, really, really hard to predict who these super responders are going to be. And I think this is where biomarkers can really help us understanding the different tumor biologies of these different patients. Maybe ctDNA can really help in this space. However, all we know is that there's a subgroup of population that no matter what you do, they're not going to have great outcomes. And conversely, there's about 1/3 of patients where they're going to have significantly better outcomes by doing a locally aggressive therapy. And so again, we look at the different tumor metrics for these patients. I really want to highlight these patients had multiple tumors. Again, 4 to 5 tumors for a lot of these patients. And so sometimes in my tumor board, they say 4 to 5 tumors is too many tumors for you to do a locally ablative procedure. I think that's not the case, and we should be a little bit more aggressive with approaching ablation. And so once you get to the higher numbers, 5, 6, 7, 8, 9, I found it very beneficial to do it intraoperatively with your surgeon. And again, going back to this close collaboration, you have to have close collaboration with your surgeons. Because if you do an open ablation, the visualization is a lot easier when you can put an ultrasound probe on the liver directly, and you can do 4 or 5 ablations, 6 ablations a lot easier. So what if we said we can only do ablation alone? And this is a really cool trial that was done. So this is called the Maverick trial, which was a multi-center European microwave ablation versus resection trial. However, the trial design is wild. I've never seen something like this, but really cool. And so what they did is they looked at a study group and they said patients who had 5 or fewer colorectal liver metastases that were all less than 3 centimeters that were amenable to both resection and stereotactic microwave ablation. Again, the stereotactic coming up again. It is super important that we start to develop better ways of targeting with our microwave ablation versus just saying, yeah, I think that's close enough. Were all treated with stereotactic ablation. So they had to be a candidate for both, but every single patient got the ablation and not the resection. And they were compared to a control group of every single patient that was part of a Swedish registry who got hepatic resection. So it's not, a randomized controlled trial because it's just a prospective single-arm trial compared to a registry. However, the Swedish registry was every single patient in Sweden who was diagnosed with liver metastasis from colorectal cancer. So in Sweden, if you have colorectal cancer and you're part of their healthcare system, all of your data was collected, presumptively anonymously, and then put part of this large national database. And so they were actually able to capture 95, 96% of all patients and comparative. So it's actually not unreasonable to consider this a closer to a randomized trial, although it's definitely not a randomized trial. And as I was reading this trial design, I'm like, this is so, cool and how they would do that. And I thought to myself, you could absolutely never do that in the US. Like I could imagine trying to tell some of my patients the government's going to collect your data and it's going to be part of some large national registry. But it was really cool that they could do that in this trial. And so what did it show? It showed that when you did propensity score matching, the overall survival was indifferent between stereotactic microwave ablation and hepatic resection. As you can see here, the two curves are essentially identical. Okay. Not only that, but again, as we saw in the HCC subgroup, we also see in the colorectal subgroup, complications were way less, 30% in the surgery group versus 10% in the ablation group, 67% reduction. So that brings us to the trial you guys asked me to speak about, which was the collision trial. And this was finished last year and presented at ASCO and essentially every other major conference since then, which was the actual phase 3 randomized controlled trial where they actually randomized patients to either get resection or microwave ablation. So very similar criteria, multiple tumors less than 3 centimeters in size. Instead of being compared to a registry, these patients were actually randomly allocated to either get surgery or ablation. This was powered for 618 patients, but it was stopped at 50% accrual, again, because there was no difference in between these two, so it was unethical to continue doing this trial. Long story short, as you can see here, the local tumor progression-free survival was exactly the same in the resection versus the ablation group. So you see the p-values are 0.5. And also the overall survival between these two groups is identical. You can see here, these two curves are perfectly overlapping. Just as we saw in the previous trial, the complications were significantly less with microwave ablation versus surgical resection. So you can see here it was 46% in the resection group, 19% in the percutaneous group. Again, very similar to the Maverick trial, where there's a significant reduction. I think what's important to keep in mind, unlike HCC, most of these patients are going to progress. So there was no difference in distant progression-free survival between these two groups, but you can see by a year, almost half of the patients did progress. So don't get discouraged when you start treating colorectal cancer that patients are progressing. Even with you treating them, they still live longer. And I think that's super important to keep in mind as you start seeing and treating these patients. You're kind of treating them along their whole cancer journey, and it's a tough disease to treat. And so again, good techniques were used in both arms. So R1 resection, meaning they had positive margins, were 12% in this subgroup. And an A1 is again having less than 5 millimeter margins on your ablation. So R1 positive margins, A1 having inadequate margins on your ablation. They showed relatively high degrees of recurrences, 36 and 47% additionally. If you were able to get a surgical margin of a millimeter, and or you were able to get a 5 millimeter margin on your ablation in all three dimensions, you had a 95% control rate. Margins are super important when it comes to ablation. And I want to make a plug here for the Society of Interventional Radiology Acclaim trial, which is 70% accrued, which is looking at colorectal liver metastasis ablation, obtaining margins and showing that there's going to be a 2-year control rate of as close to 100% as possible. So stereotactic and margins are the name of the game when it comes to this uh, uh, um, colorectal ablation. So we go to the NCCN guidelines, and this is the recommendations that the NCCN, the national group that makes guidelines for cancers, and they say local regional therapies like image-guided tumor ablation is appropriate, and they give you guidelines on how to do it. And more importantly, when we look at the treatment for patients who have chemotherapy or no chemotherapy, they say resection and or local therapy. And even though we're a small, tiny little footnote, we're now part of the guidelines all the way down here that says for small lesions less than 3 centimeters, thermal ablation is equivalent to resection. So we're part of the guidelines, guys. Thank you.
Great talks, Dr. Berman. One question that we had in the chat was, although disease progression is multifactorial, are there certain factors that are more relevant, and can the results from a lot of these trials be stratified to better understand the best candidate when choosing them for specific interventions?
Yeah, biomarkers are like the super, you know, big thing right now. We know that some genetic mutations inside the colorectal liver space, like KRAS mutants, EGFR mutations, et cetera, can be super important in predicting who are more likely to progress or not. Unfortunately, a lot of these trials don't have the granularity to detect those differences. So as of right now, if someone's a surgical candidate or an ablation candidate, we just offer it because we know in the trials there's a subgroup of population, 33-40%, that are going to be alive in 8 years versus that less than 10%, if not. So an active debate that hopefully you guys can help solve.
Yeah. And then another question that Dr. Vatican Cherry had in the chat was, how will the publication of the collision trial impact guidelines in terms of the amount of VIRs physicians that are needed to provide treatment and just the other equipment that would be required?
So I think we're part of the guidelines right now. I think it's gonna, again, instead of just being a tiny little footnote, will start to become bigger and bigger as part of it, especially as more of these trials come out. Again, the guidelines that I showed you are the 2025 guidelines. They knew about the collision trial results. Again, now we have that tiny little thing that says we're equivalent. I think we are going to need more IRs in general. That's just for everything. But we're starting to see a lot more improved technologies, whether it be robotic guidance or other stereotactic guidance systems, to help make it more democratized. So you don't need to be somebody who has 1,000 of these. If you can have technology help you localize your tumors, and then also margin confirmation software to help you make sure you get adequate margins. I think, right now what might be considered in the hands of just the expert academic centers will be democratized to a bunch of different other sites as well. And I think that's just going to take a little bit of time, and hopefully getting more IRs interested in treating these patients.
Hey Zach, this is Joji. So that's actually incorporated the data from collision. These are the 2025 guidelines.
Yeah, so as you can see here, yeah,
I got you. Okay. So
Yeah, I put it right here. So this is the January 2025 guidelines for colon cancer.
so I'm
And you can
surprised it's
say,
not based on that data. Almost, it's kind of hidden. Like why would it not be higher level or higher up? In the sense that it's equivalent based on this trial. Like,
yeah.
what would it require to say equivalent to surgical resection for this population?
So there are actually 2 additional phase 3 trials open right now.
Mm.
I didn't get into them because they're not completed yet, but they'll be completed in the next year or two. And I think once you get multiple phase 3 trials that are done kind of throughout the world and not just, the collision trial was just done in one country, in Europe. Once we have an international cohort, then I think it'll be, definitively within the guidelines. And then at the same time too, I don't think there's nearly enough IRs on any of these guideline committees, right? So we're not the best advocate for our own specialty. For instance, I'm on one of the NCCN committees, and there's only 2 IRs there out of 40 people who are on it. And so I think IR is becoming a bigger advocate for our own specialty and being on more of these treatment guidelines and kind of advocating for our level 1 evidence is super important. So um, you know, staying involved is critically important.